The amounts of water and sodium ingested and lost in your body are highly variable and affect your blood volume. Consequently, to maintain blood volume within a normal range, the kidneys will regulate the amount of water and sodium lost into the urine. Diuretics can promote this elimination of sodium and water into the urine from the body. They do this by helping the kidney to release sodium in urine. The sodium release takes with it water from your blood, and as a consequence, there is increased urine output by the kidneys when taking diuretics, which is known as diuresis. This is the reason why diuretics are known as the water pills, and why a milder over-the-counter form of diuretics that are less effective than prescribed diuretics and contain more herbal components and caffeine have been marketed to reduce bloating or water retention. The elimination of more water and sodium from the body due to diuretics also results in a decreased amount of fluid flowing through your veins and arteries. This is referred to as a decreased blood volume and results in a reduced blood pressure. Changes in blood volume affect the pressure of blood on your arteries by changing the cardiac output, which is the amount of blood your heart pumps. A decrease in blood volume decreases the central venous blood pressure, which decreases the blood pressure in the right atrium of the heart, where the heart first receives the venous blood. It also decreases the blood pressure in the right ventricle of the heart just before it contracts, referred to as the right ventricle end diastolic pressure. Together, this results in reduced ventricular preload, which refers to the amount of sarcomere stretch experienced by cardiac myocytes at the end of ventricular filling during diastole. Reduced ventricular preload decreases ventricular stroke volume, that is, it decreases the amount of blood ejected per beat from the respective ventricles of the heart, according to the Frank-Starling mechanism. When there is a decrease in right ventricular stroke volume, there is a consequent decrease in pulmonary venous blood flow to the left ventricle, therefore decreasing left ventricular preload and stroke volume. A decrease in stroke volume, that is the blood pumped from the left ventricle of the heart, then decreases cardiac output and so arterial blood pressure. Diuretics can therefore be useful for treating health conditions in patients who need to reduce their blood pressure or blood volume. If high blood pressure remains unregulated without diuretics, it can lead to a variety of health conditions. Firstly, the hardening and thickening of arteries, that is arteriosclerosis, can cause a stroke or heart attack to potentially occur. Secondly, weakening and bulging of blood vessels can cause an aneurysm. Thirdly, thickening of the walls of the heart's pumping chambers, that is left ventricular hypertrophy, can eventually lead to heart failure. Fourthly, weakening and narrowing of blood vessels in the kidneys can harm kidney function. Fifthly, thickening, narrowing, and tearing of blood vessels in the eyes can cause vision loss. Sixthly, increased chance of metabolic syndromes, including diabetes, heart disease, and strokes can occur. And finally, narrowing or blocking of arteries, which restricts blood flow to the brain and can hence cause vascular dementia. Hence, diuretics are used to treat many health conditions involving high blood pressure, also called hypertension, and diuretics are most commonly used for those with congestive heart failure who typically exhibit high blood pressure. Diuretics are also used to treat abnormal fluid retention known as edema, in which soft tissues swell due to buildup of fluid that is leaked from small blood vessels into nearby tissues. The decrease in venous pressure due to diuretics reduces the hydrostatic pressure, that is the pressure of fluid in the capillaries, and this decreases filtration of capillary fluid and promotes the reabsorption of the leaked capillary fluid, thereby reducing edema if present. The causes of this leak in the blood vessels varies from a skin infection to a twisted ankle. Please pause the video to see the potential causes in more detail. It is important to treat edema because if left untreated, edema can lead to increasingly painful swelling, stiffness, difficulty walking, stretched or itchy skin, skin ulcers, scarring, and decreased blood circulation. In contrast to edema, the etiology of hypertension is largely obscure. Only 5% of cases have an identifiable cause. It is known, however, that blood pressure is a product of cardiac output, the amount of blood the heart beats per minute, and systemic vascular resistance, the resistance that must be overcome in order to push blood through the circulatory system, and that arterial blood pressure is therefore maintained by contraction of the left ventricle, systemic vascular resistance, elasticity of the arterial walls, and blood volume. Regardless of this, diuretics are more effective in treating such health conditions in certain circumstances. The effectiveness of orally taken diuretics differs depending on the exact diuretic. For example, the bioavailability of the diuretic torsemide when orally taken is extremely inconsistently well absorbed due to the substantial hepatic elimination it undergoes. In contrast, some diuretics such as furosemide have extremely variable bioavailability. That is, the proportion of the drug that enters circulation and has an active effect varies extremely. In addition, diuretics taken intravenously are more effective and more potent than when taken orally because intravenous drugs have a 100% bioavailability. That is, since they are typically delivered directly into the bloodstream, bypassing the lengthy process of absorption of the drug and first metabolism, where part of the drug is metabolized by the liver in its first circulation through the body. Thus, the blood concentration of diuretic delivered intravenously increases faster than if it was taken orally, and so it takes effect quicker. For example, the diuretic furosemide has a peak diuretic effect between 1 and 1.5 hours after oral administration and between 10 and 30 minutes after intravenous administration. And the dosage of intravenously administered furosemide is actually only half of that of the oral dose in order to achieve the same effect. However, given the convenience and higher safety of oral diuretics compared to intravenous diuretics, for most chronic conditions not classified as severe, oral diuretics are provided because its dose is modified to equal the dose that would have been delivered intravenously, allowing for the same level of effects. Intravenously delivered diuretic drugs is mainly done for patients with more severe illnesses who have difficulty absorbing the drug, such as those with severe edema. For example, severe edema may result in inadequate gastrointestinal absorption, which modifies the effect of furosemide because it is absorbed from the gastrointestinal tract. Such patients are more responsive to intravenous than oral furosemide because it has a higher bioavailability with a lesser proportion metabolized in its first circulation through the body. But the question still remains, how exactly do diuretics rid sodium and water from the body through the kidneys? Under normal conditions, within each nephron, that is the functional unit of a kidney, the glomerulus in the nephron filters your blood, and the different parts of the tubule in the nephron gradually return needed substances to your blood and remove waste. There are 5 types of diuretics able to rid the body of sodium and water. The first diuretic type is loop diuretics. Loop diuretics act on part of the loop of Henle, which is a section of the tubule in the nephron. Loop diuretics have the greatest diuretic effect because as much as 25% of sodium is reabsorbed in the ascending limb of the loop of Henle, and by this point, other parts of the nephron are not able to compensate for the increased levels of sodium. Example drugs are bumetanide, anthracinic acid, furosemide, and torsemide. Loop diuretics inhibit the activity of the sodium-potassium 2 chloride cotransporter, located in the cells that align the thick ascending limb of the loop of Henle. This transporter typically aids in the transport of sodium and chloride from the urine filtrate in the tubule to across the cell of the tubule wall and eventually into the interstitial space of the kidney. Therefore, inhibiting this transporter thus inhibits reabsorption of sodium and chloride in this part of the nephron, which leads to a significant increase in the distal tubular concentration of sodium. Consequently, the difference in concentration of sodium between the surrounding interstitial space and the urine in the tubule is less, and by osmosis, water moves towards the area with higher concentration of a substance. Thus, less water will now be reabsorbed into the interstitial space of the collecting duct. When less salt and water are reabsorbed, this results in more sodium and water remaining in the urine and being lost. Thus, there is increased diuresis, meaning water loss, and natriuresis, meaning loss of sodium. Besides sodium and water being lost by inhibition of this transporter, potassium, magnesium, and calcium are also lost to the urine. Loss of potassium, magnesium, and calcium is referred to as hypokalemia, hypomagnesemia, and hypocalcemia, respectively, and often results in an electrolyte imbalance. Loop diuretics can also cause rapid and excessive reduction in blood volume, called acute hypovolemia, which can lead to hypertension, that is high blood pressure, shock, and even cardiac arrhythmias, that is an irregular heartbeat. Because loop diuretics inhibit a transporter that exists in the inner ear also, their use may cause hearing damage called ototoxicity. Loop diuretics can also compete with transport of uric acid at the same site, blocking its secretion via urine and leading to hypouricemia, which is an abnormally high level of uric acid in the blood and can worsen gout symptoms. Gout is a disease in which defective metabolism of uric acid causes arthritis. Loop diuretics also can induce renal synthesis of prostaglandins. Prostaglandins are molecules which have a hormone-like effect and that contribute to the renal action, including the increase in renal blood flow and redistribution of renal corticoid blood flow in this case, where corticoid refers to steroid hormones that reduce swelling and immune responses. Thiazide diuretics are the second type of diuretics and are the most commonly prescribed. Under normal conditions, sodium and chloride enter the cells lining the distal tubule via sodium chloride cotransporter, and once inside the cell, sodium is transported to the blood by the sodium-potassium ATPase pump, while chloride diffuses out into the interstitial space via a chloride channel, and thus both are reabsorbed away from the urine. Thiazide diuretics, however, inhibit the sodium chloride cotransporter, and when the sodium chloride cotransporter is inhibited, there is decreased sodium chloride reabsorption, and as water follows sodium, increased urine output. Thiazide diuretics nonetheless have less effects than loop diuretics in producing diuresis and natriuresis, because over 90% of sodium has already been reabsorbed before the urine has reached the distal tubule. Thiazides are also capable of causing vasodilation that reduces peripheral vascular resistance, but the mechanism of this is still unclear. Drugs in this class include chlorothiazide and hydrochlorothiazide that are structurally similar, as well as chlorthalidone, metolazone, and indapamide. Like loop diuretics, thiazide increases hyperkalemia as well as hyperuricemia by interfering with uric acid transport, which may exacerbate gout. While loop diuretics can cause calcium secretion, causing hypocalcemia, thiazides, on the other hand, can cause hypercalcemia, which refers to abnormally high levels of calcium in the blood. Thiazides may also worsen glucose control, leading to hyperglycemia, which means excess glucose in the bloodstream, and they may also elevate cholesterol, leading to hyperlipidemia, which refers to an abnormally high level of fats in the blood. The next group of diuretics are potassium-sparing diuretics. They work primarily in the collecting tubule of the nephron, where they inhibit sodium reabsorption and potassium excretion. Although these potassium-sparing agents are weak diuretics, they are often used in conjunction with diuretics from other classes in order to enhance their effects, or in conjunction with thiazide or loop diuretics in particularly, in order to help prevent hypokalemia, which is abnormally low levels of potassium in the circulating blood. Agents of this drug can be split based on their mechanism of action. The first group directly inhibit the sodium channel associated with the aldosterone-sensitive sodium pump, which decreases sodium-potassium exchange and thus retention of potassium. Drugs belonging to this group include amiloride and triamterene. The second group antagonize the actions of aldosterone at the distal segment of the distal tubule in the nephron. They are thus aldosterone receptor antagonists. Because aldosterone antagonists compete for binding to the intracellular receptor, there is reduced synthesis of proteins that activate sodium channels, and there is thus decreased number of sodium-potassium ATPases, which ultimately causes more sodium and water to pass into the collecting duct and be excreted in the urine, and this also leads to potassium retention. Drugs belonging to this second group include spironolactone and eplerenone. Because potassium-sparing diuretics do not promote secretion of potassium during diuresis, they do not cause hypokalemia like the loop and thiazide diuretics. In contrast, they cause hyperkalemia, which is high potassium levels. This is especially a risk when potassium-sparing diuretics are combined with other drugs that can also increase potassium levels, such as ACE inhibitors. The reason for this is that by inhibiting aldosterone-sensitive sodium reabsorption, less potassium and hydrogen are exchanged for sodium in this area, and therefore less potassium and hydrogen are lost to the urine. Less hydrogen lost in the urine means more hydrogen in the blood, which can increase blood pH and is a risk for acidosis, which refers to an acidic environment of bloody fluids. Furthermore, due to its chemical structure that resembles our natural steroid hormone, spironolactone can stimulate receptors for testosterone and progesterone, leading to effects such as menstrual irregularities in females and gynecomastia, that is, enlarged breasts, in males. Osmotic diuretics are the next type of diuretics. They work by interfering directly with osmosis. Water has a tendency to move across the membrane from a lower osmolality to a higher osmolality, that is, from a less concentrated to a more concentrated site. These osmotic diuretics are filtered from the glomerulus because they are very water-soluble and undergo very limited reabsorption due to their large molecular size. Consequently, there is thus more of these osmotic diuretics in the tubular fluid, which causes the concentration of this substance in the tubular fluid to increase, that is, for the tubular fluid's osmolality to increase. And as a consequence of this, less water moves into the interstitial space of the kidney and away from the tubular fluid, because the concentration of the interstitial space is no longer significantly larger than the concentration of the tubular fluid. Because osmotic diuretics increase water rather than sodium excretion, they are not very effective at treating edema because edema is caused by sodium retention. Instead, osmotic diuretics are mainly used to reduce intracranial pressure, that is, the pressure in the cranial cavity. They also promote urinary excretion of toxic substances and promote urine production in patients with acute kidney failure. Example of an osmotic diuretic is mannitol. The use of osmotic diuretics can lead to significant fluid changes such as volume overload, that is the expansion of volume of extracellular fluid, or dehydration and thus electrolyte imbalances. The final group of diuretics are carbonic anhydrase diuretics, which inhibit the enzyme carbonic anhydrase. Carbonic anhydrase is responsible for dehydrating carbonic acid into carbon dioxide and water and rehydrating it back into carbonic acid later. This enzyme is necessary in order for bicarbonate to pass out of the proximal convoluted tubule and be reabsorbed. Carbonic anhydrase inhibitors thus produce their diuretic effect mainly by reducing reabsorption of bicarbonate in the proximal convoluted tubule by inhibiting the carbonic anhydrase enzyme. This consequently inhibits the transport of bicarbonate out of the proximal convoluted tubule and into the interstitial space, and instead bicarbonate is retained in the lumen of the proximal convoluted tubule and is excreted as part of the urine. In addition to this, since bicarbonate reabsorption utilizes the sodium-hydrogen exchanger, inhibition of carbonic anhydrase and therefore the reabsorption of bicarbonate leads to significant reductions in proximal tubule sodium reabsorption, which ultimately results in greater sodium bicarbonate and water loss in the urine. The diuretic effect of carbonic anhydrase inhibitors is the weakest of all the diuretics because the majority of the sodium not reabsorbed in the proximal tubule still gets reabsorbed by distal parts of the nephron. However, this late reabsorption also leads to increased potassium secretion, which is one of the side effects associated with this class. Additionally, because bicarbonate is a major component of the acid-base buffering system in the circulation, the wasting of this buffer component leads to increase in plasma acidity, known as metabolic acidosis. One of the most popular drugs that belongs to this class is acetazolamide. Carbonic anhydrase diuretics are mainly used to treat glaucoma, a condition of increased pressure within the eyeball, causing gradual loss of sight. Despite the benefits of diuretics, it is important to be cautious when taking diuretics. Thus, because of the adverse side effects of diuretics, if you have severe liver or kidney disease, are dehydrated, have an irregular heartbeat, have high blood pressure during pregnancy, or are in the third trimester of pregnancy, have gout, are 65 years or older, or are already taking drugs that can damage hearing like the cancer drugs platinol and carboplatin, salicylates like aspirin and Pepto-Bismol, or aminoglycosides like amikacin and gentamine, you should consult your doctor before taking diuretics. Generally, diuretics are safe, yes, but if you have trouble urinating or are allergic to any ingredients in diuretics or sulfur drugs like Septra and Bactrim, do not take diuretics. Thanks for listening, and hopefully you are now familiar with everything you need to know about diuretics.